Hello everyone. Today I wanted to talk to you guys about tuberous sclerosis complex. Um, the reason why I'm presenting this disease identity because it is very rare, and secondly, recently we had a case of tuberous sclerosis that I saw in the clinic, and being a fellow, I was a little frustrated as what we can do about these patients other than doing surgical intervention, and if there is anything that we can do to slow down the progress of chronic kidney disease in these patients. And I couldn't get a good answer from the from the books and from the literature review. So this prompted me to do some article search, and that's the reason why this is coming up. So let's talk about tuberous sclerosis. So our case was a 57-year-old African American male. He was a nursing home resident. He is a nursing home resident. He has got a history of tuberous sclerosis. We don't know when he was diagnosed, how he was diagnosed, as we didn't had any records. But he did had a history of tuberous sclerosis, history of seizures, mental retardation, and chronic kidney disease since 2007. And this 2007 is the first record that we have got on our medical records. He was a very poor historian. He So basically what happened was that he had a fall in the nursing home sometime in July 2012. Few days later, because of the pain, they did a CT abdomen on him, and they noted that he had a right femoral neck fracture. The patient subsequently got hospitalized and got a right hip arthroplasty on the same month in July 2012. While he was in the hospital, they noted that he had a worsening serum creatinine, and subsequently he was discharged, and then he was referred to us as an outpatient. So per the patient, he was on dialysis short term nearly 5 years ago. We had no idea, no clue as why he was on dialysis, what prompted him to be on dialysis, and for how long he stayed on dialysis. But according to him, it was for a few days, and the only thing he told us that he did not like being on it. It hurted him a lot. So when he initially came in, his labs were showing hypernatremia. He was volume depleted. He did admitted that he had a poor PO intake, and then subsequent phone call towards nursing home did confirm this. He cannot swallow food properly. Had seizures time 3 in last 6 months. His serum creatinine baseline was around 1.3 in 2007, went up to 3.1 in June 2012, then subsequently went up to 4.6 in September 2012, and then he started coming to see us with hydration. It came down to 3.9, but then went up again to 4.2 in December 2012. If we look at his creatinine trend, this is his creatinine trend in the pink line. As we can see that this is right at the baseline around 1.3 1.5 area, then subsequently in late 2010 started to shoot up, and then this is the time when he was following us. So this is his CT abdomen, and as you can see in the arrows that there are certain cystic kidney disease that is there. You can see there are few AMLs or angiomyolipomas and subsequent sections at various level in his CT. And as you can see that there is a cystic disease, possible angiomyolipomas here, angiomyolipoma. I think this is an angiomyolipoma as well. But yeah, combination of cystic disease with angiomyolipomas. This is his ultrasound. His ultrasound was also showing an angiomyolipoma of around 1.15 centimeters, and there was some cystic disease, a cystic disease going on as well. So at that time, we didn't had any ideas what to do on him. Obviously, what the literature tells us is to do surveillance and then do a surgical intervention if they are having bleeding or if the size is big. So we called Dr. Bristler. We emailed him. He is obviously, as we know, that he's an authority on tuberous sclerosis. And the main question for us is that how commonly do we see CKD in this patient population, and what are the main reasons? And do these kidneys tend to enlarge in size just like adult polycystic kidney disease or not? And then we were asking about what type of surveillance do we need to do and at what frequency. And Dr. Bristler was very helpful and was very kind enough to give us a reply saying that what he thought that what he thinks is that the patients with tuberous sclerosis complex is around 90% of um, CKD stage 1, and 90% of these patients have got angiomyolipoma, whereas 60% of these patients definitely have got cyst. He recommended us to do MRI every year or two. So this is what his advice was. So let's talk a little bit about tuberous sclerosis. So it was first diagnosed in 1880 by a physician called Desire Bonville, and he described his first cases with his first case with brain lesion resembling potatoes, and thus the name tubers came in tuberous sclerosis. In 1900, John Pringle this was the first physician who described a facial angiofibromas, and he described it as adenoma sebacum. Since then, the disease was initially called as Bonville-Pringle disease. In early 1900s, there was an association that was made between the epilepsy, cognitive retardation, and angiomyofibromas. So, tuberous sclerosis complex, as we all know, is an autosomal dominant disease. It is a neurocutaneous disorder that is characterized by pleomorphic features that involve many organs, including multiple benign hematomas of brain, eyes, heart, lung, kidneys, and skin. 70 to 80% of the patients do not have a family history, and we will explain it why. And 95 to 100% penetrance, but very pleomorphic. So the mutation for tuberous sclerosis complex happens in uh, genes TSC1 and TSC2. TSC gene 1 is in chromosome 9, and TSC2 gene is in chromosome 16. These are tumor suppressing genes. Now we do have a two-hit hypothesis for pathogenesis of tuberous sclerosis, which means that your first mutation should happen in a germline, and then the second mutation should happen during life, so it should be a somatic mutation that should inactivate the remaining allele. Now the cause of so the pathogenesis involved is because of the mutation of TSC1 and 2 genes. The gene product of TSC1 gene is called hamartin, and the gene product for TSC2 gene is called tubulin. So when we talk about pathogenesis, what happens is that different cytokines, due to the influence of different cytokines, growth factors, hormones, etc., we have production of TSC1 gene product and TSC2 gene product. What this gene product do is it activate your Rab signal pathway. So Rab is a signal transduction protein of RAS. So it gets activated. When Rab gets activated, it activates your mTOR, and when mTOR gets activated, it do two signals, signal 1 and signal 2. The signal 1 is the main signal that stimulates renal progenitor cells. Now what happens when the renal progenitor cells get activated? It can either differentiate into mesenchymal or epithelial differentiation. For a mesenchymal differentiation, we can have angiomyolipoma formation or oncocytomas or carcinoma formation. When we have got a epithelial differentiation, we can have cyst formation. So if we look at the clinical manifestations of tuberous sclerosis complex, the manifestations are numerous, and therefore this is a pleomorphic disease. But for the sake of interest, if we limit ourselves towards kidney manifestations, we can say that it can involve angiomyolipomas that can happen in 55 to 75% of cases. We can have epithelial cysts that can be present up to 45% of cases, and renal cell carcinoma that can happen in 2 to 3% of cases. So remarkably diverse, it affects kidney in a very diverse manner, and we can have multiple cysts in, as we mentioned, around 30% of cases, and that leads to chronic kidney disease and hypertension formation. We can have oncocytomas, we can have renal cell carcinoma. Now the renal cell carcinoma in this patient population is little interesting. Usually in general population, renal cell carcinoma happens when someone is 50 to 60 years of age. In patients with tuberous sclerosis, they develop renal cell carcinoma in their 30s. And finally, angiomyolipomas can happen in majority of cases, around 75 to 80% of cases. We can also have nephrolithiasis or stone formation. This can happen because of tubular dysfunction, because of the cyst formation itself, or we can have carbonic anhydrase inhibitions from the epilepsy medication called topiramate that we use to prevent seizure activity. What topiramate do is that it decreases citrate excretion, and thus it influence or thus it causes more stone formation. And there are cases where there is associated polycystic kidney disease. What happens is that the TSC2 gene and the polycystic kidney 1 gene are located in the same genes, and a mutation in TSC2 gene can also cause mutation in polycystic kidney 1 gene, and this can causes more severe cystic disease. So let's talk a little bit more about angiomyolipomas. So angiomyolipomas in tuberous sclerosis patient is multiple and bilateral lesions. Um, Mostly angiomyolipomas are benign tumors that are composed of abdominal vessels, immature smooth muscle cells, and fat cells. In one study, they found out that 80% of children that were diagnosed with tuberous sclerosis had renal lesions by 10 years. Of these renal lesions, they had 75% of cases had AMLs and 17% of cases had renal cyst. So angiomyolipomas can even start at infancy. There have been cases reported about that. The leading cause of mortality in tuberous sclerosis patient is because of angiolipomas. What happens is that the angiomyolipomas, as we just discussed, is composed of abdominal blood vessels. These abdominal blood vessels can form aneurysm, and they can bleed from aneurysms in nearly half of the cases, especially when the angiomyolipomas are more than 4 centimeters, and nearly one third of these patients present to the ER in shock state, where you have to very aggressively resuscitate these patients. Just think about a kidney biopsy gone bad. There are two variants of angiomyolipomas. One is with adipose tissue, which is very common, which is the most common type. The other one is epithelioid type, which is more difficult to diagnose and which is more difficult to differentiate it with the cystic disease because of a less adipose tissue formation. Then the large angiomyolipomas theoretically can encroach into a small tissue and have the potential to culminate in the kidney failure. This is how the angiomyolipomas and the cystic disease causes progressive kidney disease. So if we look at the diagram here, we can see that we have got angiomyolipomas here. These are very big lesions, and if we look at the angiogram of the same patients, you can see that there are big aneurysms. There are aneurysms everywhere, and these aneurysms are more prone to bleed, and they can cause hemorrhage in these patients, which is an indication of intervention. We will talk about it. Um, other Different patient, different manifestations of polycystic kidney. You can see that tumor burden, the pathology burden is very significant, and if you look at the angiogram on these patients, they have got aneurysms, and these aneurysms again are more prone towards bleed. So what are the current treatment options that we have got? Well, the surveillance is obviously very, very important. What they guide us, what they tell us is to do a surveillance on these patients. The surveillance can be done either through ultrasound or an MRI. They recommend that we should do an angiographic catheter embolization if there is a hemorrhage going on, if there is a significant hemorrhage going on. We do a surgery if the angiomyolipomas are more than 4 centimeters. The reason being, an angiomyolipoma of more than 4 centimeters are more prone towards hemorrhage or bleeding, and the main cause of mortality in these patients is because of hemorrhage. And the surgery involves nephrectomy, usually nephron aspiring nephrectomy, and transplant in cases of recurrent or life-threatening bleeding. So let's talk a little bit more about surveillance in tuberous sclerosis. The reason why we do a surveillance in tuberous sclerosis is because we want to detect the benign and the malignant tumors. We want to detect tumors in these patients, and we know that there's a chance that the benign tumors can convert into a malignant tumors. This is the reason why we do surveillance. The surveillance has to be done in kidneys, brain, and soft tissues, and the risk starts at infancy. This is really important. The focus on monitoring the development of benign and conversion to the malignant tumors, as we discussed. The guidelines are recommended by Tuberous Sclerosis Consensus Conference that was published in 1998 to 1999. So what the consensus tell us? The consensus tell us that for surveillance we should have a renal ultrasound at the time of diagnosis. So when you make the diagnosis of tuberous sclerosis, you need to have an ultrasound done at that time to ascertain that there is an absence of polycystic variants of tuberous sclerosis complex, or you want to make sure that there is no AMLs. You want to repeat a renal ultrasound every 1 to 3 years. You do it every 3 years if there is no lesion seen in the prior scan. Now, if you think that there is a malignant transformation going on, or if you think that there is a development of large AML, which is more than 3 to 4 centimeters, then it has to be evaluated. It has to be imaged by either an abdominal CT or more preferably an MRI without contrast. Interventional radiology can be consulted for treatment of lesions greater than 3 to 4 centimeter uh, because we want to prevent hemorrhage. Now, having said that, what does this tell us? These consensus guidelines tell us how to do a proper surveillance, so we know about that. This consensus tell us what to do when the patient is bleeding or when a complication is happening. It does not tell us anything as if we can slow down the risk of progression, how we can uh, reduce the burden of the disease, how we can slow the progression or halt the progression of chronic kidney disease. And to be very honest with you, I find myself stuck with this patient, as really if there is any benefit I can offer to him other than just doing imaging on him, and then finally if he comes to that point that he is bleeding and he's bleeding to that death, I will be doing an intervention on him. um, I really don't have any clue at that time, and that's the reason why we emailed Dr. Bristler in the first place. So, in order to understand the update on tuberous sclerosis, I will be presenting these three articles. These are very good articles. One article is itself published by Dr. Bristler in NEGM in 2008. We will talk briefly about it. Then we will talk about this article over here that was published in 2011, very recently, in American Journal of Cancer Research. And then we will talk about an exceptional case report where a Spanish institute actually treated one of their patients with low dose rapamycin, and we will talk about uh, their story. So let's talk about our original article, the first article that was published on sirolimus that used the mTOR inhibitors for tuberous sclerosis. This was written by Dr. Bristler. It was published in 2008 in NEGM. It was a 24 months trial. It was 24 months study, non-randomized open-label trial. The aim was to see if sirolimus can reduce the angiomyolipoma volume in patients with tuberous sclerosis or sporadic lymphangiomyomatosis. Sirolimus was administered for 12 months. MRI was used to evaluate angiomyolipomas, usually at month 2, 4, 6, 9, 12, and 24. And the brain lesion was evaluated with the help of a CT, and a CT and a PFT was done to evaluate the lung cyst. 25 patients were enrolled. 20 patients completed study for 12 months, and then 18 patients completed the study for 24 months evaluation. This is the study design. So their primary endpoint was to look at the angiomyolipoma volume in 1 year. Their secondary endpoint was to look at the angiomyolipoma volume in 2 years. They wanted to look at the cyst volume in year 1 and 2. They want to look at the spirometric measurements, lung volumes, diffusion capacity, and 6 minutes walk test. Uh, they use a sirolimus initial dose of 0.25 milligrams per meter square. The level was checked at 2 weeks post when they started sirolimus, and then adjusted to keep the levels between 1 to 5 nanograms per ml. At 2 month follow-up, they were looking for the size reduction, and if they had a size reduction of less than 10%, then they were going up on sirolimus to a target level of 5 to 10 nanograms per ml, and then they were seeing the patient again in 4 months, and if in review in 4 months again, if they had a less than 10% reduction, then they were going up on sirolimus dose to a target range of 10 to 15 nanogram per ml. The dose that was chosen at 4 month or month 4 was continued to month 12, and this was this is what was recorded in the study. So what they found out was that there's a there's a mean 30% reduction in the AML volume, and with these patients on sirolimus in year one. What they figure out is that the patient, when they started on sirolimus, within 12 months they had a significant reduction of cyst size or the AML size, and then when these patients were stopped taking sirolimus, and when they were stopped giving sirolimus, then their AML volume went up again. So a mean of 30% reduction with a maximum of 70% reduction from the baseline. Uh, this is one of the um, MRI pictures from one of the patients, and if you can see that they had angiomyolipomas here and here. Baseline at 12 months, their disease load was much reduced. So compare this, compare that with that, and with what they were suggesting is that with 12 months treatment with sirolimus, their AML volume was shrinking. They looked at the pulmonary function test. What they looked at was the forced vital capacity and forced expiratory volume in 1 second. And what they saw that with FVC in 1 year, they had a 390 cc's increase in forceful vital capacity that did decrease down to 346 cc's when they stopped giving patients sirolimus. And same goes with FEV1, that within 6 months, while they were on sirolimus, the FEV1 increased to 120, and then subsequently 218 cc's in 12 months, and then it dropped down to 75 cc's and on the month 24. So still we can see that from baseline, um, they had an increase of 390 cc's and 346 cc's in month 24, and they can still had an increase of 75 cc's as compared to baseline for FEV1. If we look at the reserve volume, the reserve volume was actually decreased by 439 cc's after 1 year of sirolimus treatment. So the effect came on the decrease, and then after, when they stopped giving the sirolimus, they started going up again. The side effect profiles, usually GI with aphthous ulcer, mucositis. Patients were having diarrhea, they were having upper respiratory tract infections, sinusitis and bronchitis. They had dyslipidemia, so this was one of the main side effects, and they had soft tissue swelling. Um, Also reported to have a sexual reproductive dysfunction. The major side effects requiring hospitalization include diarrhea with dehydration. Patients had pneumonia, pyelonephritis, stomatitis, and hemorrhage related to angiomyolipoma. One patient developed cellulitis in his or her lower extremity after a cat bite, and we all know that wounds are difficult to heal when the patients are on sirolimus. So, if you want to summarize Dr. Bristler's study, it was a very good study, the first of its kind, done for 24 months, non-randomized, open trial to see if sirolimus reduces angiomyolipoma volume. 25 patients were enrolled, 20 patients completed the first 12 months, and 18 patients completed the first 24 months. They had a decreased volume of angiomyolipoma of around 53.2%, or 20 plus minus 26.6 of the baseline, and at 24 it was 85.9 plus minus 28.5 from baseline. Uh, what they also said that at 24 months, 5 patients had persistent reduction in angiomyolipoma volume of 30% or more. They also showed improvement in FEV1 and FVC. with the use of sirolimus, and their reserve volume also improved with that. The cerebral regions remain unchanged, and 5 patients had 6 serious side effects, which include diarrhea, pyelonephritis, stomatitis, and respiratory infection. So, with this being said, this study was actually published in American Association of Cancer Research Journal. It was published in 2011, and it was also a very good study. Basically, um, basically the same type of a study that was done by Dr. Bristler, that was published, that we just talked about. The purpose of this study was to investigate the efficacy and safety of mTOR inhibitors, sirolimus, for the treatment of angiomyolipomas in patients with tuberous sclerosis. This study was a multi-center study. It was basically done in United Kingdom, and multiple centers in United Kingdom, and then one center in Switzerland between 2005 to September 2009. It was a phase 2 trial, non-randomized, open-label trial. 16 patients were enrolled, 13 were females and 3 were males. They found in their study, per the Fleming single stage design, they were saying that for their study to be statistically significant, they should have a 14 patients. So they ended up having 16 patients in their study. Uh, for them, the inclusion criteria was a definite diagnosis of tuberous sclerosis complex or a sporadic lymphangiomyomatosis if they were between the ages of 18 to 65 years, at least one AML of greater than 2 centimeters in longer diameter, and they should have a GFR more than 40 mLs per minute. For the exclusion criteria, the patients were excluded if they were embolized in last 6 months, or if they had a bleeding in last 12 months, if the urine protein to creatinine ratio was more than 1 gram per day, if they were unable to walk 100 meters flat, if they were requiring home oxygen or supplemental oxygen, or if their IQ was less than 70. For the data collection, baseline MRIs without contrast was done. Up to 5 AML with longest diameter of greater than 2.2 centimeters was selected as target in each kidney, and the longest diameter was used. AML less than 2 centimeters were termed as non-target AMLs. They use the oral sirolimus as a daily dose of 0.5 milligrams per meter square, with a dose adjustment adjusted to keep the levels between 3 to 6 was used. Remember, the levels was around 1 to 3, I guess, in Dr. Bristler's study, and it's 3 to 6 over here. The follow-up visit were at 3 weeks, and then 2, 4, 6, 9, 12, 18, and 24 months after initiation. If the target lesions was not reduced by 10% at month 2, sirolimus dose was increased to keep a target at around 6 to 10 nanograms per ml. For the imaging, they use the MRI for MRI abdomen to look at the renal angiomyolipomas. This was done at baseline, that at month 2, 6, 12, and 24. The CT of the lung was done at baseline and at 24 months. They use a single radiologist to steady all of their imaging, and they reduce the bias through that. The PFTs, the primary function tests, were done. They measured FEV1, FVC, and DLCO. It was measured at baseline, that at month 4, 6, 12, and 24. And they used neurocognitive testing as well at baseline and then in month 4 and 12. So this is their study protocol. So 19 patients with tuberous sclerosis were screened. 16 were enrolled. Of those 16, 6 had sporadic LAMs, 3 had tuberous sclerosis with LAM, and then 7 had tuberous sclerosis only. So of those 16 patients, 14 underwent neurocognitive assessment at baseline, 16 had angiomyolipoma measured at baseline, and 9 with sporadic LAMs had primary function assessment done at the baseline. So sirolimus was started on these 16 patients. Uh, one missed out in the 2 month evaluation, so they had 15 patients at the month 2 of evaluation. They had significant numbers of withdrawn. The reason why they were withdrawn is listed over here. So one had lung transplant, one had AML surgery, which was an elective. Two had a protocol deviation, one had developed edema because of sirolimus, and one died because of pneumonia. So 10 patients completed 24 months trial. and at 2 months, 4 patients had dose escalation. So they use something called a RECIST criteria, which is a response evaluation criteria in solid tumors. Our hemong colleagues will know about this. But they use a RECIST criteria for evaluation or to see the response. For them, a complete response means disappearance of all lesions. For them, a partial response means a decrease of at least 30% of target lesions without progression to non of progression of without progression of non-target lesions. Progressive disease was defined as an increase of 20% in the size of target lesions or appearance of one new non-target lesion. And for them, the stable disease was either no response and no progression. So while this is steady, if we talk about response, the response will be at least a decrease of 30% of the target lesion without progression of non-target lesion. Again, target lesion was an AML greater than 2%, 2 centimeter. Non-target lesions were AML less than 2 centimeters. What they found out is that they had a response rate of around 50%, so half of these their patients did responded with sirolimus. AML diameter reduced in all 16 patients, and by 30% or more in 8 out of 10 per protocol patient. 41 of 48 patients with AML were smaller than baseline. Most shrinkage occurred in the first year of treatment, as you can see. First year of treatment, there was a most significant shrinkage, and then subsequently the shrinkage was not that significant. Uh, for the response of pulmonary function test, they did not see much change with sirolimus, and there was no clinical relevant changes in the lung CT either. Response to neurocognitive function was also very variable. They figured out that they had improved immediate recall and executive functions, but the immediate recognition scores actually decreased. So variable response with neurocognitive function. Side effect profile was very extensively studied, and the most common side effects were oral mucositis, respiratory infections, and proteinuria. The serious adverse side effects or events happened was that two got hospitalized because of pharyngitis and chest infection. I really don't know what chest infection means. I'm gathering it probably might be pneumonia, and one actually died of respiratory infection. So just to summarize, in a trial by Dr. Bristler, AML volume was increased after sirolimus therapy, was withdrawn after 12 months, returning from 53% to 86% of baseline value in 24 months. In this current trial that we just discussed, it was shown that the tumor response was maintained by continuation of therapy to 24 months, but little further shrinkage occurred after first year. Now, long-term sirolimus therapy may be needed to prevent further regrowth, tumor regrowth in these patients. This could be acceptable in organ transplant recipients as well. So now we know that in these trials, which are which are phase 2 trials, we know that sirolimus or mTOR inhibitors actually can work. But does this recipe really work in real world? And there was a very good case report that was published in the Journal of Nephrology Dialysis Transplant in 2010. It was a Spanish case report published from Toledo, Spain. And what they did was that they used a low dose rapamycin to one of their patients with tuberous sclerosis, and they wanted to share their story with us. And so let's talk about their story. So they had a 40-year-old gentleman who was diagnosed with sporadic tuberous sclerosis at 10 months of age, after initially presenting with facial angiofibromas and epilepsy. He had a controlled. His epilepsy was controlled on anti-epileptic medications, and anti-epileptic medication was therefore discontinued at age 25. He was a graduate in geography and history, so a very educated person. He presented in 2006 with frank pain, abdominal distension, fever, hematuria, which was macroscopic, and he was in a shock state. His creatinine at the time when he was presented was 1.6. Ultrasound and CT showed kidneys with bilateral AMLs and different size cysts. The bleeding culprit was the AML lesion at the upper pole of the left kidney that showed evidence of large intrarenal hematoma. There was some scattered AMLs in the liver as well. So this is the diagram, or this is a picture for his CT, and as you can see that there is some intrarenal hematoma, and there is some angiomyolipoma and cystic. So angiomyolipoma is a cystic disease that is present. So finally, now we are here. So finally, his renal function deteriorated with the serum creatinine that went up to 1.9 from 1.6. They did a mag scan on him that showed the right kidney was 65% working, the left kidney was 35% working. They did a conservative and supportive treatment on him. Patient and the renal function did stabilize. They did a follow-up CT on week 5, which showed again the bilateral AMLs with relevant decrease in hematoma size. So now, with a supportive and conservative treatment, his serum creatinine was improving, and his hematoma size was reducing down. So he was offered a selective embolization, but the patient refused. His serum creatinine back down to 1.5 at the time of diagnosis. Remember, I came in with 1.6. So his repeat CT here, you can see that there is big hematoma. Over here, the hematoma was resolving. This is the follow-up CT in the 5 weeks. So then what happened was that he came in on November 2007 again with hypertension and dyslipidemia now. He was started on various antihypertensive medications. Successive regular imaging or follow-up imaging showed that his AML was enlarging, and subsequently they were having hard time in controlling blood pressure. His creatinine went up from 1.9 to 1.9. Remember, at the time of discharge, it came down to 1.5. It went up to 1.9 again, and they did a CT brain that was showing calcified nodules in cerebellum, lateral ventricle, and cerebrum. So finally, they started him on rapamycin. They started him on a 1 milligram per day oral dose for 12 months. They aim for a trough of 1 to 4 nanograms per ml, and according to them, the treatment was very well tolerated, and the MRI was done in at baseline when when the rapamycin was started, and then on month 12. So this is his creatinine and protein to creatinine trend here. So what they found out was that if you look at this MRI, you can see there is a big angiomyolipoma, or the disease here, and there is a disease here. And post rapamycin after 12 months, compared this with this. So size from here to here reduced down from here to here, and this longitudinal diameter from here to here reduced down from here to here. So there is a clinical significant reduction in volume, and a different axis on the CT. You can see, if you can see the outline here, this is his outline, and this is the outline on the other side. And if you compare this with this with this, and you can see that there is a significant reduction in the volume. So what they found out, that MRI showed a total decrease in kidney volume from 1480 cc's to 1224 cc's. This was actually a 17% reduction. The right side decreased by 16%, the left side decreased by 22%. His GFR actually increased by from 47 to 52, so there is like a 6 cc's per minute increase in the GFR, which although is not that much, but still there was no progression of his kidney disease. Patient tolerated treatment with no significant side effects. His hematological parameters and LFT remains normal. Dyslipidemia remained controlled with simvastatin 20 milligrams that was used, and his atenolol was actually discontinued. So his dyslipidemia and his blood pressure was very well controlled, and they continued him on rapamycin even after 12 months. So this was a success story. And just before I end up in our update on tuberous sclerosis, just last week there was article published on Lancet, January 10. Today is what, January 15th. So 5 days ago there was an article that was published in Lancet by Dr. Bristler again, and he termed his trial as Exist 2. Unfortunately, I cannot pull it up as I saw this morning before presenting it, but it was a multi-centered, randomized, double-blind, placebo-controlled trial, and he had 98 patients. And very briefly, let's talk about his results. And what he found out that the angiomyolipoma response was 42% for everolimus and 0% for placebo. So what he found out that the everolimus reduced the angiomyolipoma volume with a acceptable safety profile, suggesting that it can be a potential treatment for angiomyolipomas associated with tuberous sclerosis. And with that, I must conclude by saying that uh, here is a disease which I totally understand that it is very rare, but still it exists. Patients do have mental retardation and seizures, but some of the patients are really intelligent. And when I was treating my patient, or when I was reading it, I found myself handcuffed, thinking that there is nothing that I can do for these patients to prevent them ending up in dialysis, or prevent them getting unnecessarily surgeries. And I've got the answer now. I think if their EGFR is good, if their GFR is more than 40, if uh, if compliance is not an issue, then I think mTOR inhibitors are the way forward. And with that, I thank you all for listening to this presentation. Thank you.